When it comes to lung tumours, there are a couple of things that can be included in questions or included in radiology reports that can give a key to its underlying condition. Now, of course, these are blanket terms. There are always exceptions to the rule, but in general, anything that's caveating or cavitating will form a cavity. It's normally a squamous cell lung tumour, if that is the primary pathology. If there's phrenic involvement, it will reduce the diaphragm movement, so the diaphragm can be flat and there can be difficulty breathing. So if there's difficulty breathing from diaphragmatic movement, you need to query whether there is a phrenic nerve involvement. If there is a small cell carcinoma suspected, this can secrete ACTH. And small cell cancers also contribute to a paraneoplastic syndrome called syndrome of inappropriate ADH secretion that you should know about in detail. Let's look at bronchial carcinomas in a bit more detail. These can be divided into small and non-small cell carcinomas. So very few small cell carcinomas within the bronchial tree can indicate surgery, unfortunately, and that's because over 80% of these patients have metastases at presentation. With non-small cell bronchial carcinomas, the most of the pathology is squamous, and these are the most common, and they cavitate, they form cavities, as we've already said in our previous slide. You would only CT brain these patients if clinically indicated. We know that lung cancer is metastasized to the brain. You would get a PET CT in these patients. And you should remember that liver mets, adrenal mets are common in these patients, so you should have a high index of suspicion and consider scanning there. This is why you get a PET CT scan of the whole body. A sad fact about lung cancer is the most common cause of cancer-related deaths in the UK. A lung cancer plus an exudative effusion with cells in it is almost always unresectable. And that is just a blanket term. Of course there's going to be exceptions, but in general a lung cancer with an exudative effusion with cells is not going to be a good outcome for the patient. Let's spend some time now looking at transitive processes and exudative processes. Usually these things come about whenever you're talking about pleural effusions, for example. The best way to classify transidate and exudate is transidate is a systemic process and exudate is a local process. So looking at the transitive processes, systemic processes first. These pleural effusions normally come about by things like congestive heart failure, cirrhosis, nephrotic syndrome. These are all processes that decrease the hydrostatic pressure, decrease the oncotic pressure of your blood, so water moves out of cells, fluid moves out of cells or the blood and into the pleural space, and this causes a bilateral pleural effusion normally. Whereas an exudate is a local process. An exudative effusion is caused by cancer, tuberculosis, acute infection such as a parapneumonic effusion. We're going to look at a couple of different aspects of transidates and exudates now. And how we look at transidates and exudates is via Light's criteria. So Light's criteria is broken down into LDH levels, an LDH effusion and serum ratio, and a protein effusion to serum ratio. So you look at the blood and you look at what's in the effusion that you've tapped. In transidative effusions, the LDH is less than 200. In LDH effusion serum ratio, it's less than 0.6, and protein effusion serum ratio is less than 0.5. So all these things are lower because the transidate is more water-like, if you forgive the simplification. Whereas exudates have LDH levels above 200, above 0.6 for the LDH effusion to serum ratio, and above 0.5 for the protein effusion to serum ratio. So all the values are the same. The transidates are just below those values and the exudates are above those values. Some textbooks quote the protein levels as 30 grams per litre instead of the 0.5 ratio. And even just one of those characteristics of an exudate makes it an exudate. So it doesn't have to be all three, it can just be just one. And this is called Light's criteria, and it's really important you remember this. This does crop up in exams, and it's important to realise. So the causes of transidates in the body, and we're looking specifically at pleural effusions this time, can be cardiac, renal, liver in nature, any of those, from an endocrine process such as hypothyroidism, or from nutritional deficiency like seen in alcoholics or people with liver problems with low albumin. And these are all failures. Transidates are caused by failures. And about 10 to 20% of pleural effusions, I've said PEs here, I probably should have written pleural effusions out, but of pleural effusions are transitive. They're transitive processes. They also account for about 5% of malignant pleural effusions, which is why it can be confusing sometimes. But if you do a quick literature search, you'll see that a very low percentage, 5% of transitives can be malignant. You will also see transitive effusions in Meg syndrome, in atelectasis, and with peritoneal dialysis. Now, as we already know, an exudative process is a local process normally, and it is associated with increased LDH levels and increased protein levels in that fluid. It can also arise from a hemorrhagic effusion that's caused by tuberculosis, for example, but also with pulmonary thromboembolism, because that can cause a transidate or an exudative process, even from the hemorrhage associated with pulmonary thromboembolism. Cancers and malignancy are some of the biggest causes of exudative process, such as CA lung, breast cancer, mesothelioma, and lymphoma. Sometimes a parapneumonic effusion can be an exudative effusion, and this is normally caused by something like strep pneumoniae, and you need to ensure in this case that there is no abscess formation, because that can be a common cause of a parapneumonic exudative process. And if you have a lymphocytic exudate, you might want to consider lymphoma as part of your differential, and this is sort of makes sense, because if you have a lymphocytic exudate you might suspect lymphoma, but you should also suspect tuberculosis. What are the characteristics of a pneumothorax? So the first thing you're going to see with somebody who's having a pneumothorax is potentially shortness of breath or even pain in the chest. Once you've done your basic ABCD approach, make sure they're not tensioning, etc. Say it's just a standard pneumothorax, a spontaneous pneumothorax. What are you going to look for? You're going to chest x-ray the person, and you're going to look for lung markings. You're going to trace your finger around the lung markings and make sure they go all the way to the edge of your lung fields, and you're looking for an airline at the edge of the lungs, and there's a separate video that I've done specifically looking at the edge of the lungs for pneumothorax. These spontaneous pneumothoraxes are common in young, thin men. They're also common in patients with Marfan syndrome, emphysema, abscesses in the lungs, tuberculosis, or trauma to the chest, quite obviously. You must beware tension pneumothorax, and you will be looking for tracheal deviation on an examination, but you will be also looking for mediastinal shift. You'll be looking for tracheal deviation away from the midline, away from the spinous processes on an x-ray, and your definitive treatment in the emergent setting is a thoracocentesis with a cannula in the chest wall. Otherwise, you're going to be putting a chest drain in a more elective way. It's still an emergency, but you're going to be putting a chest drain in to drain that pneumothorax away, to drain the air away from the pleural space. The other thing you need to consider, that if you do a thoracocentesis, you're automatically subscribing that person to a chest drain. They're going to get a chest drain. If you put a cannula in their chest, they need a chest drain. But it is an emergent setting, and you're trying to do your best to avoid a massive emergency. A chest drain is better than death, quite obviously. A lot of students ask how we know when it's time for an ICU admission or it's time for an ICU intubation, emergent intubation. And the answer is, it's not an easy decision. In fact, there's a lot of debate that goes on between hospitals. So in the first instance, you would refer to your own department's protocol, but you would also, the first thing you would do is seek senior help and seek attention from the ICU or HDU staff in order to make these decisions about referral. Even discussion with somebody on the phone is very important. Generally, ICU admissions, even HDU admissions, that aren't necessarily post-operative, which can be a bit more obvious if somebody is post-operative and they are sick. They can sometimes go to the ITU, the ICU, but in a deteriorating medical patient, for example, or surgical patient, the indication is normally organ support. So we're offering organ support above and beyond what a ward can do. Other indications include persistent hypoxemia despite escalating intervention on a ward. So that means the patient is still hypoxic despite nasal specs, despite face mask oxygen, despite all the max nebulizers, despite putting the person on non-invasive ventilation or AirVo, which is high flow nasal oxygen. Their oxygen demands are increasing. That means their FiO2 is increasing. The fraction of inspired oxygen you're giving them is increasing, but it's not helping their PaO2 and their ABGs. Their CO2 might be increasing, like in asthma, where they have an obstructive lung pathology and their CO2 is climbing and climbing and climbing. They're not able to ventilate, this means, so they're becoming more narcotized with CO2. The patient might have an airway injury from burns or laryngeal edema. That might indicate an admission to ICU or an ICU intubation. Other reasons for an ICU admission might be an altered mental state, so the patient is totally non-compliant with any medication or intervention, and that means they're thrashing about, they're becoming non-compliant, they're becoming more sick, and they don't know where they are, or they have neurological depression, and that usually means a decreased GCS, so they're not able to protect their airway, and an intubation is indicated. I would say that if you're revising from this video for finals, there are a number of things that you should do in all emergencies. Treat patients you're considering an ICU admission in as an automatic emergency. You are a fact finder, you are an information gatherer. Make sure the history that you've taken from the patient is up to scratch. Make sure you've done up to date and reliable investigations, such as apply all the monitoring you can on a patient, apply supplemental oxygen, ABGs, up to date ABGs. You're looking for chest x-rays and things like that to facilitate the ICU team making a decision on the disposition of the patient. I've added a slide here on Cheyne-Stokes respiration because this is coming up in a couple of exams over the past number of years. Is that Cheyne-Stokes respiration is breathing with a rhythmic wax and wane of depth of breath and a regular recurring apneic episode. So basically this means that there's a rhythmic wax and wane of the depth of breathing, so the depth of breathing gets higher and low, so shallow and deep, and there's regular recurring periods of apnea or no breathing. Causes of unilateral clubbing, it's worth a very quick slide. 2 causes of unilateral clubbing. 1 is axillary aneurysm or damage or trauma to the axillary artery. 2 is coarctation of the aorta. Worth another very quick slide is pleural plaques. Pleural plaques are seen in about 50% of asbestos workers. You can see these on chest x-ray or CT, and they are not always pre-malignant. They can be, but they're not always, and you'll see it in about half of all asbestos workers. Carbon monoxide accounts for about 75 deaths per year in the UK. We've got better at detecting it with household carbon monoxide detectors. Our boilers and heating systems are much more compliant with health and safety executive mandates. The way to approach the patient with carbon monoxide poisoning is you put all monitoring on them, BP, SATs, approach them with an ABCD approach. They will have full sats on oxygen. You give them supplemental oxygen, and they'll have the full saturations. They'll have 100% oxygen saturations on an O2 monitor, but they cannot release the oxygen to the tissue, so that's why they get a tissue-related hypoxia. So the PaO2 on their ABG can be normal, but if you look at the co-oximetry, you will see their carbon monoxide levels in their body are not normal, and they can have a variety of ways of presenting. The reason behind all this is the curve of your oxygen hemoglobin association curves shifts to the left, which means that the oxygen molecule, hemoglobin, holds on more tightly to the oxygen and to the carbon monoxide, so will not dissociate. Oxygen will not dissociate at the organ site. The patient will present with nausea, headache, malaise, weakness, unsteady. With focal neurology, they might have a low GCS, for example. And your treatment plan will cover a number of different things. The first thing is you're trying to displace that carbon monoxide with 100% oxygen, and that's either with a face mask, non-invasive ventilation, or in worst case scenario, an endotracheal tube. This has the purpose of trying to reduce the half-life of carbon monoxide from 6 hours to 1 hour. So you can be doing this for quite a while before it works, but you need to get to it to prevent that tissue hypoxia from getting even worse. So hyperoxygenate them in the first instance. The second thing to do is potentially refer this person for hyperbaric oxygen therapy. This isn't used much this day. I worked in a centre that had a hyperbaric chamber for oxygen therapy, but it's not used very much. We found that hyperoxygenating people who you get to early, so quite often you can find people who've been exposed to high levels of carbon monoxide have died due to hypoxia. If you've got to them early, it's a mild case. Hyperoxygenate them, reduce that half-life of carbon monoxide down from 6 to 1 hours, and hopefully you'll be okay. Monitor their level of tissue oxygenation, monitor their lactate, because that can be a sign of tissue hypoxia, and ensure they get the right treatment with a bit of fluid, for example, if they're hypotensive or they need a bit of lactate washout. So tuberculosis is not very common in the UK anymore, but still you will see it in the UK. If you go somewhere like India, you'll see it all over the place. TB, tuberculosis, things that can be talked about in the exam is the vaccine, the BCG. The BCG vaccine, how it's gone out of favour quite a lot, and this is seeing a recurrence of TB in endemic areas such as London with high immigrant populations. You could be talking about the gone foci, for example, on CT or chest x-ray, and cavity formation within the chest. Miliary TB, where there is disseminated tuberculotic lesions throughout the chest. You can have systemic TB or pulmonary TB. Systemic TB can literally hook itself onto everything. You see patients from a long time ago who have had spinal TB, pelvic TB that's gone to the bone, metastasized to the bone, and caused some terrible illnesses in childhood, for example. In 2014, there were 1.4 million deaths worldwide from tuberculosis, so it is by no means gone in the world, even though there's vaccination for it. A growing problem with TB is multi-drug resistant TB. This is increasingly common. We're not going to focus on the different drugs you're going to look at for multi-drug resistant TB. We're going to be looking at the ripe mnemonic for the main antibiotics: rifampicin, isoniazid, pyrazinamide, and ethambutol. And that is the ripe mnemonic, RIPE. Infliximab, which is an anti-TNF drug, can activate TB. This comes up infrequently in SBA questions. So looking now at sarcoid disease. Sarcoid disease can cause a restrictive lung disease. It causes interstitial lung disease. However, it is a multi-system disease that is characterised by non-caseating granulomas. So it doesn't just affect the lungs, it can affect anywhere in the body, any organ system. It has an increased incidence in Afro-Caribbean young adults, and 40% of people can be asymptomatic with this disease. The disease cutaneous manifestations are things like erythema nodosum, which you will see on the shins of the patient, and you should Google a picture of erythema nodosum so you know what it looks like. These patients can be plagued by polyarthralgia from all the deposits, the granulomatous deposits in the joints, for example. If they have pulmonary manifestations of sarcoid, they will have a dry cough, they will be short of breath, they will have increased levels of anti-CCP, not as much as rheumatoid arthritis, but they can have increased levels of anti-CCP. They will have a hilar lymphadenopathy that can sometimes be seen on chest x-ray, but much more sensitively seen via a CT or a high-resolution CT scan of the chest. These patients have lymphadenopathy throughout their body. They can have eye disease, they can have lupus pernio, and they can have a number of other conditions such as hypercalcemia and increasing sizes of their parotid glands and lacrimal glands. So the cause of sarcoidosis is unfortunately unknown. Some scientists believe it is due to an immune reaction to a trigger, such as the infection or chemicals in those who are genetically predisposed to this. If you have an infected family member, you're at greater risk of having it. Diagnosis is based on signs and symptoms and also supported by a biopsy. Findings that make it more likely include those large lymph nodes we've talked about, particularly at the root of the lung, the hilar lymphadenopathy, the hypercalcemia in the blood, with a normal parathyroid hormone level, I must say, or an elevated level of angiotensin converting enzyme, so ACE, in the blood. The diagnosis should only really be made of somebody after you exclude tuberculosis in some of these patients as well. It can resolve without any treatment after a couple of years, but some people have long-term and severe disease with multi-system involvement. Using anti-inflammatory drugs like ibuprofen can work, and steroids like prednisolone. Sometimes in very severe disease you have to go on to modifying drugs such as methotrexate, chloroquine or isothiopurine, and they can decrease the side effects of steroids. So if the steroids are becoming too bad, you might want an immune modifier such as methotrexate to be involved. Your risk of death is between 1 and 7%, and there's less than 5% chance of the disease returning in somebody who had it previously. So I'm just going to go through a couple of things about sarcoid again. Investigations might include an ASR, which would be raised liver function test. It can be off due to the granulomas in the liver, for example. You want to make sure that's not happening. Hypercalcemia with a normal parathyroid level. Polyuria. On chest x-ray they might have pulmonary infiltrates, bullae and honeycombing on CT, pleural involvement, a high serum ACE level, angiotensin converting enzyme level, and pulmonary function tests would be normal or decreased. Treatment for this patient, as we've already said, would be bed rest, would be non-steroidal anti-inflammatory drugs, steroids like prednisolone, and then on to things like methotrexate and azathioprine, etc. So just a very quick slide now on respiratory failure. Type 1 respiratory failure is seen in hypoxia, so you have a low PO2 but a normal PCO2. Type 2 respiratory failure is where you have a low PO2 and a high PCO2. So type 2 respiratory failure is characterized by failure to ventilate, and type 1 respiratory failure is typified by hypoxia, but you are ventilating, you're ridding yourself of CO2. Type 2 respiratory failure is more common in things like COPD, even asthma, once it gets very bad, can have type 2 respiratory failure if you're having an acute exacerbation. And type 1 respiratory failure, for example, if you took all of the oxygen out of a room, you would have a type 1 respiratory failure. Pneumonias and things can cause a type 1 respiratory failure as well. What would you do if you saw a solitary calcified pulmonary nodule on an x-ray? Hopefully the first thing you'd be thinking is this cancer? Is there something really wrong with the patient? So you have to look at their history, and a number of things correspond to an increased risk stratification for this patient. Their age, if they're an increasing age, if they're a smoker, are they short of breath, are they cough, have they any symptoms associated with chest disease? If they are at low risk, you would arrange surveillance of this nodule. You would x-ray it, you would CT it at intervals as described by your radiology department for up to 2 years. If high risk, you would arrange a CT scan, further scans of it, and you would arrange a biopsy to characterize the lesion, the nodule. Now, this might be quite old information, because nowadays if you see anything on a CT scan, the immediate first thought is to get a biopsy, get it looked at, get it sorted, because you don't want to miss anything. However, nowadays I think we are probably biopsying and CTing a lot more of these people, removing the node and finding more negatives. That's okay, but as long as you have a process in which to talk through low risk patients and high risk patients, and the concerns that you might have over this calcified nodule. Finally, now let's clarify some x-ray views. A PA x-ray is a posterior anterior chest x-ray, is the standard form of x-ray for looking at the chest. This is what would happen if your GP sent you up and you were to get a chest x-ray in outpatients. This would be done with the patient upright, the arms abducted, so away from the chest wall, and the board is in front of the chest, so you are facing away from the x-ray beam that is behind you. And this PA view is the standard view. An AP stands for anterior posterior view of the chest, where the beam is in front of you. And this happens when the patient's in bed or in ICU ventilated, for example, and the patient's unable to stand or abduct their arms, etc. like that. This is done in bed, and you're unable to comment on the heart size normally. If you're looking at an AP view, this is the non-standard view. So all of these views are with respect to the beam and the board. So if you look at a PA view, the PA view of the chest is posterior anterior view, where the x-ray beam passes through the first thing that's mentioned in that AP or PA. So if it is a PA, the beam passes through the posterior aspect of view first, then leaving through the anterior view of you and into the board. If it's an AP, it will hit the anterior portion first, pass through the posterior portion and into the board, and that's all it's describing.